Hello everyone, welcome back. Today I'll be covering dynamic hip screw that usually and can be asked during viva or OSCE session. Started off with an introduction, indication and complication of DHS, parts of dynamic hip screw, 1. Leg screw and the barrel, 2. The side plate, techniques of DHS fixation, tip impact distance, TAD, and lastly regarding biomechanical study. I hope it helps. As an introduction, dynamic hip screw or sliding screw fixation is an implant assembly consisting of a leg screw, a side plate, and cortical screw which fix the side plate to the proximal femoral shaft. This figure shows the parts of dynamic hip screw. The first one is the leg screw. Inside there is a compression screw. Then the side plate with barrel and cortical screw fix it to the femur. Hip fractures. The choice of surgical treatment is the best strategy for the hip fractures, which has the advantage of early rehabilitation and functional recovery, and reduces the risk of prolonged immobilization. Example, risk of developing deep vein thrombosis, pulmonary embolism, PE, sacrosor, orthostatic pneumonia, etc. Published papers supported the indication of dynamic hip screw DHS for the treatment of stable fracture. Example, stable intertrochanteric fracture, basicervical fractures, and transcervical fractures. The parts of dynamic hip screw. Number 1. Leg screw. It is a special screw that allows sliding motion, hence the name dynamic hip screw or sliding hip screw. The screws are available from the size 50 mm to 145 mm to match the neck length across the population. It has threaded diameter of 12.5 mm and the thread length of 22 mm. The shaft is slotted to fit the barrel and has a length of 8 mm. The shaft and barrel slots fit each other so that the screw is able to slide inside the barrel but cannot rotate. Again, this illustration shows the parts of dynamic hip screw. On the distal aspect of the shaft of the leg screw, the inner side is threaded. This is for placing compression screw after the screw and plate assembly has been fixed. The purpose of compression screw is to pull the leg screw towards the barrel as the compression screw is tightened. Short barrel dynamic hip screw side plate is preferred when screw is less than 80 mm. In such cases, the screw prevents disengagement of assembly as well. This figure shows the DHS component, the barrel component. On the most right hand side, it shows the short barrel. Number 2, regarding side plate. Plate barrel angle is around 130 to 150 degree. The barrel plate angle matches the neck shaft angle. 135 degree is most commonly used. Plates are available in varying sizes, 2 holes to 16 holes. Commonest use is 2 holes or 4 holes. More explanation at the end of the video. The barrel lengths are 25 to 38 mm. Again, this figure shows the parts of dynamic hip screw. Techniques of dynamic hip screw. After correct indication and consent taken, patient is on traction table. Close reduction is performed prior to the draping under image intensifier II guidance. After patient is clean and draped, the proximal femur is exposed through an incision extending from greater trochanter for approximately 8 to 10 cm distally. The lateral femur is exposed and a guide wire is drilled from the lateral femur into the femoral head. To avoid rotational displacement during screw insertion, place an anti-rotation wire parallel and proximal to the head-neck axis. This figure shows the anti-rotation wire from the AP view and the lateral view. The guide wire should be centered in the femoral neck in both the AP and lateral view. The angle between the wire and the femoral shaft must equal the angle of the fixation device, around 135 degree. The tip of the guide wire must lie in the center of femoral head and 5 mm or 1 cm from the subchondral line on both the AP and lateral views. This figure shows the insertion of a guide wire for the screw in AP view through the center or slightly inferior to the neck. Lateral view around 5 mm or 1 cm short from the joint. After the guide wire is confirmed to be in place, the cannulated reamer, also called triple reamer, is used to drill over the already placed guide wire till the tip of the wire. The reamer is set to the correct depth as measured on the table by a direct measuring device. The leg screw is inserted into the femoral head after tapping of the drill channel. This figure shows the triple reamer. As you can see, there's a rim for the threaded part of the screw. There's a rim for shaft, rims for barrel of plate, and rims for barrel plate junction. On the right hand side, the imaging is clearer. There is a marking on the reamer along to set for desired reaming length as measured by direct measuring device. Again, the reamer is cannulated and reams over the guide wire. The side plate and barrel are placed over the screw and attached to the femoral shaft with screws. Image intensifiers are done throughout the procedure to ensure the maintenance of the reduced fracture position and proper positioning of the fixation device. 2-hole to 6-hole plate can be used in intertrochanteric fractures. Longer plates is used in subtrochanteric fractures. It is desirable to obtain compression at the fracture site. For this, traction on the affected limb is released and compression screw is inserted. Then, finally, the wound is closed in layers. This figure shows the barrel and the leg screw. The barrel will glide over the leg screw. And then lastly, compression screw is partially threaded on the rear part of the leg screw and inserted lastly after of the traction. The risk of screw pull out by measuring the tip apex distance. To achieve a center-center position, we can use the tip apex distance TAD. It is sum of the distance from the tip of the leg screw to the apex of the femoral head. It is measured both in the AP and lateral radiograph. The tip apex distance must be less than 2.5 mm for minimal screw cut out. This figure shows the tip apex distance. Again, the tip apex distance is the sum of the distance from the tip of the leg screw to the apex of the femoral head. You can see XAP and measured in AP and lateral view X lateral. Lastly, regarding the biomechanical study, failure mechanism in sliding hip screw implants mostly by fracture collapse, cut out and plastic deformation of the implant. Rarely, pull off of the side plate from the femoral shaft, breakage of the implant, or disengagement of the cervicocephalic compression screw from the barrel of the side plate may occur. For cortices fixation of the side plate is sufficient to prevent pull off of screw from the bone. Yan et al. Show that 3 screws provided an optimal distribution of tensile force to prevent side plate pull off from the femoral shaft. Another favorite question. Which one would you choose? 2-hole versus 4-hole plate. McLaughlin et al. Compared the biomechanical strength and stiffness of 2-hole and 4-hole dynamic hip screw construct used for fixation of unstable trochanteric fractures, equivalent to AO/OTA 31A2 fractures, created in the cadaveric femora. They found that the 2-hole DHS was biomechanically as stable as the 4-hole DHS, and there were no side pull-off from the femoral shaft. Rock et al. Demonstrate in osteoporotic bone, 2-hole and 4-hole side plate are comparable in regards to axial and torsional stiffness and load to failure. This figure shows an X-ray of the 82 years old that have a simple intertrochanteric fracture, and she was treated with a 2-hole dynamic hip screw fixation. Yay! we have reached to the end of this video. I hope it helps. See you in the next one. Take care and bye.